Welcome. How many are new? Oh, that's good. Thanks for coming. We're blessed tonight to really have who I think has become the premier arrhythmia surgeon in the Gulf South, maybe even wider than that. Dr. Mike Brothers come talk to us tonight about surgical approaches to atrial fibrillation. Because really when you think about it, what do you do with someone with Afib? You leave it alone and give up? Or you use pills? Or you do procedures? Or you do surgical procedures? And Dr. Brothers and I, about 5.5 years ago, made the decision to embark on at that time, little known surgical procedure called a hybrid convergent procedure. And we've been borne out in our faith by having now done a couple hundred patients with it, and he's going to talk to you about our results. So we're blessed to have him. I've enjoyed working with him for the last 5.5 years. You got to know Mike to know how meticulous he is. If you're a patient, you want that kind of meticulousness brought to your care. So without further ado, I'm going to let Mike take over and tell us a little bit about arrhythmia surgery.
That's not too bad, is it? All right. Well, thanks for coming. I recognize some of you from the past, and I understand that we've got some folks here that are we're going to be seeing in the clinic. Jim's always reminded me to try to keep this simple, and it's always a big job for me because this is it's not really a simple subject, but I'm going to try to make it interesting to you, because when I talk to patients, those of you who have seen me before, one of the important things I think is to really understand where we've been. And so I'm going to make some hopefully simple statements, but show you some very complicated things. Now let me start out by saying the hybrid convergent maze is the last thing we will talk about. So if you keep that in mind, the stuff we talk about leading up to that really is historical, but very, very important as this whole treatment business changes. And it's going to be different 10 years from now than it is today. And when people look at me funny when I say that, but I always reach down and get my cell phone. And this group, I can tell in the age that we're here in the audience, you realize we didn't even have cell phones just a few years ago. And now many of you don't even have landlines in your house. So this technology is really changing quite a bit. I also tell people that for about 6,000 years of recorded history, we didn't cure anybody with atrial fib up until the late 1980s and early 1990s. A lot of what's now known as electrophysiology started by some great pioneers in the field of cardiac arrhythmia surgery, mostly at Duke University. We'll see if we can get this to roll through. Atrial fibrillation has been described by some of the experts as basically a disease of aging. Now, we can show you a lot of stuff and facts. There are 5 million people in the country with atrial fib, 160,000 cases annually. These numbers vary depending on the source, but they're still very big numbers. 25% of people over 40 will experience atrial fib at some point, and it's possible that 15 to 20% of all of the strokes occur because of atrial fib. So Jim and I have always been concerned, and I think neurologists are concerned, we may even have occult strokes that we're not recognizing when people are in atrial fib, maybe at 2 o'clock in the morning, but when they come into the hospital with a stroke the next day, they're back in sinus rhythm. The appendage of the left atrium, a little floppy thing I call Sanders hat that sits out on the side, is a source of clot in atrial fibrillation. So it's a big, big deal. Anticoagulation is indicated for most people with atrial fib. Jim and I believe that just controlling the heart rate with a lot of drugs that slow the heart down is not the same as having a natural rhythm. The one God gave you is the one that works the best. Now, it doesn't mean if you have atrial fib, you're going to die because you have atrial fib, but that next to the bottom line tells us, if you look at statistics, you see that people with atrial fib, on average, if you look at a lot of people, they don't do as well as people that don't have sinus rhythm. There are a lot of other causes for atrial fibrillation, lung disease, pneumonia. There are quite a few young people who have experienced atrial fib after a binge in college with alcohol and sometimes other drugs. The things that we see very common that are not just getting old are hypertension, pericarditis, there are tumors, there are all kinds of things that can cause it. But it doesn't really matter a whole lot because in the end it's the arrhythmia you have and we want to try to take care of it. The gist of the whole thing is in the sinus, a sinus rhythm, Dr. McKinney would call a normal sinus rhythm. It starts up in the top of the heart in those upper chambers in what's known as the atrial node, and it travels down between the two chambers at the top and the two chambers at the bottom and gets conducted down to the heart much faster into these fibers into the heart. And that lub-dub that we get, that constant regular rhythm, is a result of the sinus rhythm and what we know is a sinus rhythm. Now, there is something called Flutter, which I kind of think atrial fibrillation is really, I think of it as a bunch of flutters. I'm sure that doesn't meet the electrophysiologist definition, but it's still something that's gone awry in the conduction system, and these signals are flying around in a pathway they weren't designed to fly around in. And if you get a bunch of these things going on and things that are known as rotors and different sites that may fire on their own, then you wind up with what we know as atrial fibrillation. And that is never regular. It doesn't conduct well to the bottom of the heart, and you wind up with atrial fibrillation. This happens to be the first arrhythmia back in the days at Duke University and other places that was tackled, called atrial flutter. Most often it was in the right atrium. There's also a theory that there are multiple wavelets. I think of this as, and now that we approach hurricane season, it's kind of like having the hurricane map when you see these big balls of weather flying out from equatorial Africa. This is possibly something that's going on with atrial fib, and there's some technologies now to look at that, but nobody really knows for sure. What we do know is the back of the heart, where you see these things occur in the left atrium, the back of the left atrium, not the front, the back, is an area that most often may be excitable and where we may see these abnormal patterns. And that's really all you need to know about it. There are some nerves that seem to be located on the back of the heart and nerve cells that are thought to be quite important. And there's some other chambers of the heart, some veins that are back there that we think are important. That will come into play throughout the entire discussion of atrial fibrillation. Every procedure, every surgical procedure that's ever been done focuses on the back of the left atrium. So if you're looking at your picture books or you're Googling that later on, just think about the back of the left atrium. Everything that really, that we know about this now, I attribute in the early days at Duke University to this man, is James Cox. And when you get on the web, you're going to see the Cox Maze referred to. The Cox Maze is the gold standard. I think Jim would agree the Cox Maze is still, we have not replicated the Cox Maze with other procedures yet. I think it's coming. We're getting close with the hybrid convergent, but there are parts and pieces we cannot do. This man spent years in the laboratory back when it was fashionable to work on primates. He also had a lot of people working with him as he developed in the laboratory a very complex open heart surgery procedure done on the heart-lung machine. It's a big operation. We still do this operation. We don't do it very often because obviously everyone doesn't want to come in and have a big scar on their chest and go on the heart-lung machine. But this is the gold standard. It was actually changed several times because of some minor things that involved some details we won't get into, but it's known as the cut and sew maze. And Jim Cox is still alive today. He's been retired for a long time. But this was the end of the 6,000 year period of no cures for atrial fibrillation. People who have the Cox Maze, by the methods they used back in those days, were free of atrial fibrillation 93%, 10 years after the procedure. Recent data in survivors, which there are fewer now because they're older, is still somewhere north of 90%. So again, the gold standard. This is just a picture, just to tell you how complicated the Cox Maze was. This is a diagram of the heart and that back wall, as well as the right atrium, and a lot of cutting and sewing done back there. I'm using a mouse wheel, but that looks like it's jumpy. It doesn't work otherwise. So the Cox Maze was done for some time, and along came this guy who was working with Dr. Cox and is now currently, in my opinion, and most people's opinion in the world's leading expert on the Maze procedure. He is now the chairman of the Department of Surgery at Washington University in St. Louis, where Dr. Cox was chairman. He also was in Jim Cox's lab at Duke and did a lot of the fundamental work and research in the Cox Maze. And what he wound up doing was to find out that we could use radiofrequency energy instead of having to do a Benihana on the back of the atrium and chop it up like a quilt and sew it back together with this big operation on the heart-lung machine. We could still do it on the heart-lung machine, but we could use maybe radiofrequency energy, sort of like a burn, to make the same lines. Because all we're trying to do, all Jim does in his procedures, if we use ice or cold or cryo or radiofrequency energy, or you cut something in half and sew it back together, you're trying to get a line which does not conduct the normal myocardial signal. So he demonstrated that this was feasible in animals, and what we see, if you imagine this is one wall somewhere in your atrium, the muscle looks pink on one side and the other, right in the middle there's this area that's kind of pale and green on this slide. You cannot get a signal to go from the right side of the screen over to the left and vice versa. It's electrically neutral. So what we're really doing is trying to build up areas of insulation to make a pattern which, again, Dr. Cox figured out, with trial and error, actually works. Now, do we have a real high-powered scientific explanation of why that particular pattern works? No, it's a result of a lot of trial and error. Because, again, atrial fib is still not well understood. The normal conduction pathways are well understood. I don't think atrial fibrillation is well understood. Now, he could do this and also suggested that all of the stuff that Jim Cox did, his mentor, could be done with radiofrequency energy. He came out with a study and showed that that could be done. I want to show you a little bit about how this operation is done. It's just fun to look at the pictures. There will not be a quiz. Jim tells me don't get too complicated. I apologize in advance. But I think it's just colorful. And we like to give this talk in a slightly different variation to some of our technical people and people in surgery and some of the nursing staff. And it's still a very complex subject, even for me. This is just a diagram of a lot of lines and cuts and burns and things that are done in the full Cox Maze. This is not the hybrid convergent maze we will talk about at the very end of the talk, the one that Jim and I are doing now. But historically, it's very important. Around the heart, where the lung veins meet the heart, he has substituted this clamp which can place burns on the heart-lung machine, so now you can open the heart, and in this particular phase, the heart is actually beating, believe it or not. And you can make these various lines. Some are cuts, but many have been replaced with extreme cold, called cryo, or can be radiofrequency energy. It doesn't matter as long as you produce a pattern of isolation that you desire. The left side of the heart, there's a different pattern. This is a different chamber being opened and closed. And all of this takes about 50 minutes, 65, 70 minutes. But now, today, it's usually done along with heart valve surgery, or coronary bypass surgery. So some of you that are looking at atrial fibrillation, for instance, you've maybe come here tonight, hear about the hybrid Convergent Maze, you would not have this procedure unless you really wanted it. But most patients having the Cox Maze today already have to have heart surgery. They've got to have the chest open, they have to be on the pump, so it makes sense that we ought to do the very best operation that's available, and that's this one. Now, we'll move along a little bit. So the first step in moving toward, let's not do a big Cox Maze, how can we, with all this technology moving along, maybe we can make this a little simpler. So the surgeons jumped on the wagon about the same time as the electrophysiologists did and tried to tackle people who had atrial fibrillation part-time. They didn't have it all the time. They were in and out, on and off. And there's a lot of thought today amongst cardiologists that if you have atrial fibrillation on and off, we feel like it's going to lead eventually to more on than off, and eventually you'll be in it all the time. And then eventually you'll be in it a very long time, and it's called persistent or chronic. And this is very difficult for us to treat. The Cleveland Clinic, Mark Gillenoff and others got together and figured out they could use this radiofrequency energy that Damiano had demonstrated in a laboratory that works, and isolate the veins by using a clamp that looked like this. This clamp and this pattern, by the way, is trying to accomplish exactly what Cox did in his maze, and it's also exactly what is being done today with the cryo balloon, if I'm not going too much of a stretch, Jim. What we're trying to do is get that pattern around the lung veins on both sides. And so the next step was to do something that seemed like it was a little bit simpler by going through the chest, not doing heart-lung surgery, not having a big scar or sternotomy, having all that baggage and recovery to go through, but do it through some small openings in the chest. At first it was small incisions, and we'd take a light and we'd look inside and we'd make some holes and we would sneak down there and use some crude instruments, and we were able to do this. James Edgerton was probably the most active in this field. Jim is still a young man but disabled now, unfortunately. He lives in Dallas. And he taught us a great deal about this procedure. In fact, he was in this hospital in the first case I ever did. He came here. And part of that had to do with trying to see if we could get some of these nerve cells annihilated with the radiofrequency energy. He published a lot of data along with some other very famous people in surgery and demonstrated that this would work by going around the veins, by going in the chest on both sides. So the next operation, we have this fancy machine. I like to think of this as sort of the second step, the intermediary, the big Cox Maze being first. Then shrinking this down to where we were doing little holes on both sides of the chest. Remember, both sides of the chest. You got to do the right side. And when the patient's asleep, you got to go around and do the left side, and then you do some other stuff. So it's still, you know, it takes a lot of time. It was simpler in terms of not being as invasive, but it's still more challenging than what we do now. We have all sorts of little tools that the company is still in business that does this. We can listen for arrhythmias. We can also burn things with a little probe that we have. This was a style of probe used that we don't use anymore, but could lay down a line, if you will. Instead of spot welding, you could line up an area 2 or 3 inches long by overlapping this. And this is the way it looks. Incidentally, we do a lot of our surgery now this way, for much more surgery we do now for lung cancer and thyroid conditions, esophageal problems. But this is the same approach that we use to get into the chest. That incision for instruments is how we started. That disappeared not too many years later, and everything was done with small cameras. This is the exposure. It looks like on the right side, just a couple of holes, one that was a little bit bigger and in order to get this clamp in that provided the burn. And this is the left side. It's very similar. It's a mirror image. Again, not something this crowd's going to have to worry about the details. But once you were inside, you could get down with a camera, and the patient not on a heart-lung machine, not having hardly any blood loss, and we could do this type of operation by simply dissecting around the lung bed with this lighted instrument and be able to produce the burns that we wanted to do. In the lower left-hand corner, you could see how this little clamp could squish things down and allow you to actually make the burn all the way around. And this is the clamp being passed around the heart. Heart's beating. You're not on the heart-lung machine. And once the clamp was placed in position, it was closed. There are no blood thinners given, oddly enough, and the burn can be created there. We'll skip through this part. There's another area close by that's really important when we did this procedure, and we would try to eliminate that. Jim Cox and his landmark work demonstrated this was a very important area. And just this shows you what Dr. McKinney lives, this is the world he lives in, all these squiggles. But I'll just call your attention to the line that you see when this line, these two here, just all of these marks. As you're listening with electronic equipment, once you do burns or ablation, what you'd like to see after the fact is this. You have demonstrated that there is a block. You have demonstrated that you have isolation. Or if you're an electrician, you might call it insulation. But in any event, that's a very complex subject that I don't quite understand, but I still quite mesmerized at times watching what Jim and Dr. Zhao do. Now, the atrial appendage is the source of misery in atrial fibrillation. It is, again, Santa's hat hanging off the left atrium. It is fibrillating. Unfortunately, it is shaped sort of like a windsock or Santa's hat. And inside of it, there is very cave-like muscle with strands. You imagine a nice swamp cypress tree, the type of roots you might have coming out of it. That's what the inside of this thing looks like. It tends to attract clot when the atrium is not contracting the way God made it. So the clot piles up there. Now, I want to tell you, the rest of the atrium on the inside is smooth as a baby's butt. There's nothing slicker than the inside of the atrium of the human heart. The inside of this appendage, why it's that, I don't know. I have no idea why it's this way. Some people theorize that this is really a pressure regulator and it can change volume and size, but no one's ever really proven that. But when you're in atrial fibrillation, it's a bad thing. If you're in sinus rhythm, we were born with, it's a good thing. So, the Cox Maze got rid of this appendage. The thoracoscopic maze I just talked to you about through the chest, when we were on the left side, we would take that appendage off. Now, truth in lending, I want to fast forward and tell you, the hybrid convergent maze, at least today, we are not approaching the left atrial appendage. We can't figure out how to get there from here safely, but we are getting there. We're working on that, and we have some patients where we've done 2 different procedures. Now, I can tell you a long time ago, certainly with the surgeons in the Far East would tell me they didn't want to mess with the atrial appendage anyway. Said, why don't you, if you get somebody to sinus rhythm, who cares? If you can get your atrial fib fixed, which we do in a majority of cases with a hybrid convergent maze, then you'll be like everybody else, and your risk of stroke would be very low. Of course, the problem with that is we can't guarantee that we're going to cure everybody with atrial fib, and we can't guarantee that people that we cure aren't going to go back into atrial fib. We do have patients in their 50s and occasionally in their 40s we're not promising anybody we know what's going to happen 40 years from now. Maybe 50 years from now. People are living longer and longer. As you probably know, some of you have heard me say this before, when Roosevelt and Lyndon Johnson designed all this Social Security and Medicare, it wasn't going to cost anything at all because we were all going to be dead. And we fooled them. What happened now with clean water and public health and vaccinations and good general medical care and some rescue emergency operations, we're now living in longer and longer, and 95-year-olds are out playing golf. It's breaking the bank. So one of the issues that we face in all of this is how do we really approach atrial fib and look at it as a long-term national health problem, which is becoming because we're growing older and we have an older population. Jim Edgerton did some other great work looking at lines around the heart. It was even in 2008, it was called the Dallas lesion set, which he even copyrighted. So let's talk about what's new now. And again, I want to just remind you, if you're confused, I'm not too confusing yet, am I, Jim? All right. You guys can stop me if it doesn't seem clear. But we're talking about, to me, and I'm a surgeon giving the talk, nothing was really done forever until Jim Cox got on the scene and became extremely famous around the world. If there were a Nobel Prize in cardiac surgery, Jim Cox would probably have gotten it in the 1990s. He certainly got every other accolade. That's our benchmark. Open heart surgery, big operation on both atria. Then came a lot of really smart people, and the technology developed about the time that you could take a picture with your cell phone and it actually, you could tell who it was. I don't know if you remember, the cell phones didn't have cameras. Now we have cameras that are 3 millimeters in diameter, and you can take a panoramic picture, 12 to 15 megapixels. You see it all the time now. So that technology, imagine being able to see, and fibers that could produce light, that you could see anything, anywhere, and magnification. On another side of this, people like me that probably would have retired 10 years ago, I'm still working because I've got visual aids. I've got a screen and a camera. If I can't see something, I just blow it up. And when we do these types of surgeries, the second part, the generation of thoracoscopic procedures with cameras and lights and long instruments, we could adjust the screen where we wanted to. We weren't bent over in a hole with a coal miner's light. We have instruments came up to speed, technology came up to speed, and we're still doing really neat operations that way today, every day, other than the atrial fib. We've moved away from that in atrial fib now to a simpler operation, which we're going to talk about last. So there are 3 parts. I think the legacy Cox Maze operation. There's all of the smoke and mirror stuff going through the chest, which we call the mini maze. And now we're at the point of talking about what we will call the hybrid convergent maze. Another caution. If you're looking on the web, as I know you do, this is a very confusing subject. A mini maze to someone in Seattle is not going to be the same as a mini maze to a surgeon posting on a website in Tampa. It's not going to be the same between electrophysiologists. One of the reasons is there's so many variations now, it's difficult to have a real codified standard. But also, to some extent, some people don't really understand what the other side is doing. And some people like Jim Cox, as a purist, doesn't like anything called a maze. Now, you don't say mini maze in front of Jim Cox. There's only one maze for Dr. Cox, but it's too late. The horse is out of the barn. We talk about mini maze, we talk about mini ablations, we talk about hybrid convergent maze, with cryo balloon, cryo maze. It's out there. It's a confusing topic, but you get the idea. We want to do insulation or isolation with burns or cold material or cut and sew and produce a pattern that we know historically has provided the best shot at relief from atrial fibrillation. So, The idea now was, instead of the electrophysiologists who came along and were doing really great work with catheters, and they also benefited from this technology, but also the surgeons working on their own, it was quite a change, as Jim pointed out 4 or 5 years ago, that we started working together, and we didn't make this up. There were some other very innovative people who got involved with this first, and we followed suit. Actually, I followed Jim. I'm the surgeon, and I thought, well, this procedure I'm going to tell you about now, this is nuts. And he said, no, Mike, we got to go look. We got to look at everything, because he looks at everything. I said, well, okay, I'll go. And of course, within a few weeks, we weren't doing the other operation at all. We were doing this, and this is what we do all the time. Very rarely are we going backwards. We're doing the latest and greatest operation. Because we're doing two things. We're doing a procedure that the surgeon can do best. He's doing the part he can do best and safest and fastest and most effective. I do something in this procedure that would take Jim a long, long time to do and expose some unparalleled danger in trying to do it from the inside of the heart. I, on the other hand, can't do what he does inside the heart with catheters, with the heart beating. I wouldn't know where I was anyway. With his sophisticated equipment, he can do that. So I tell people the simple thing about a hybrid convergent maze, again, the take-home point, if I had a final exam question, is what you're going to see, what we do on the outside of the heart, the back of the atrium, the surgeon, under direct vision, with almost perfect safety and almost no blood loss, is part of a match or a key and a lock. Just think of my fingers here just being a cartoon if you were drawing a schematic. And what Dr. McKinney and Dr. Zhao do from the inside is a pattern, very complicated, but they're doing it inside the heart on the other side of where I had been. And if we do this job right, what we have done is accomplished a very effective lesion set, because I can't do what he does, not today. And he can't do what I do very effectively. He can do it, but it has some risk. And I think people who are doing this just with, or have been doing it for a while now, just with catheters that don't involve surgery, Jim, does it take 7, 8, 9, 10 hours? I don't know how long it takes.
7 to 12 hours.
And you have to use radiofrequency energy, as patients are also exposed to a lot of fluoroscopy and radiation time during the course of this. During the surgical procedure, my part, there's no fluoroscopy. There's no radiation at all. None. This is a picture of the device that the company, that we're, now there's one company, actually, believe it or not, that's got control of everything that's important in atrial fib ablation on the surgical side. And here again, doesn't matter how you do it. This happens to be just a coil that develops a lot of radiofrequency energy. And if maybe the guys in the room, if you've dealt with transmitters at all in the old days, or if you were a ham radio operator or a CB operator, you know radiofrequency energy, it really causes a very nasty burn. But it's also, when you control it, it's your friend. You can use it to your advantage. And that's what that is. This is the device. And this is the pericardial access. Now, this is one central area that we're going into the back of the heart. We're going to the same place that Dr. Cox did on the pump. We're going to the same place that we struggle through on both sides of the chest to open the heart sac and get the lung down and sneak around, use all kinds of long instruments. We're going to the same place, but we're going at it from a different direction. I usually tell people, instead of knocking on the front door and you're in the living room, I'm sneaking around the back of the house, I'm coming up the kitchen steps, and I'm going to surprise you from the dining room. And I'm making one incision to do that. Now, I have a camera port, and I got a little thing I can put a grasper in, but we're going to make an incision in the abdomen. So what you see right in the middle is this big cannula. There's an incision that's been made that's very well tolerated. This cannula just looks like a pipe, plastic, flexible, and we move that into the heart sac, and we can run right down to the back of, imagine this, the back of the left atrium. Now this is the area where you can place now this device which produces electrical energy, the radiofrequency energy, the one that causes the burn, and we can lay this thing just about anywhere we want to, but here's the key. This is my part of the contribution to this procedure. Now, as soon as Dr. McKinney and the other technologists in the world figure out how to do this from the inside of the heart, or do it outside with some sort of Spock and Dr. Bones, you know, weird device out of Star Trek, this is the way we're doing it. But when they figure out how to do that, I won't be doing any of this anymore. But right now, and for the foreseeable future, it looks like surgery and electrophysiology are going to be linked at the hip in order to do this, and this is why we're calling this a convergent procedure. Now, I might tell you, we've done all these together. This is the way this has started out. There may come a time when we're going to do the surgical part, and the part with the catheters might be done at another time. It's just a matter of convenience. It might be a matter of safety. It might be a patient selection. It may be patient choice. But this is what we're doing. This is the back of the left atrium. And we're making these burns side to side, back and forth, to create this box that Dr. Cox brilliantly demonstrated to us by almost committing a lifetime of his adult work to bring this success to us. We're looking down the inside. The device was originally designed to go up on the front of the lung vein on one side. You can go up on the other side. You can do a lot of fancy things with it. But we have determined our important role as surgeons is the back of the left atrium, the so-called box. This is another graphic showing as we look, and we're looking with a camera. We have the camera I told you about right down the barrel. So we're looking at a screen. We've got a couple of screens in our hybrid lab, not too much smaller than the screen that you're looking at here. There are screens everywhere, so whatever you want to bring up, you can take a look at. So we're not straining to look at it. We're sitting there very comfortable. If we need to look closer, we just zoom in. If we want to back out, we back out. Let's see if we can get this to... I may have to go back one. This is, I would give credit, this is Bill Bodefeld and Savello is the electrophysiologist, sort of our sister partners in crime that are up in Baton Rouge. They show them actually making this incision. The little insert, you'll see the instruments we're using, the surgeon here, but the picture is what they're looking at on the screen. So instead of opening the chest, on either side there's this little hole. This guide, the little plastic pipe, goes in, and then at some point they slide right down the back of the heart into the heart sac, and once they get down to the back of the atrium, you see the left atrium there. All these letters are referring to anatomic points, usually for surgeons, but basically the pulmonary veins, the vena cava, and they just spin this thing around. What you're looking at is the atrium. And by the way, we see this much better than you see on this film. This film is actually several years old, but it was one of the first productions made by the company, the original company who developed these devices. But you can see in the inset that he's sliding this little device in and just manipulating it with his hand. It's got the arrows on it. A child can do this if appropriately proctored once you get into the space. You just have to be very careful to make sure that you are touching the area you want. There is a burn, if you want to call it that. It looks just like a burn. You see it looks like a little railroad track. And oddly enough, you can do this with all day long, and you don't have any real damage to the function of the atrium. The back wall of the atrium doesn't seem to do a whole lot anyway as far as pumping or helping out the heart. It's really the heart sort of hung there by that wall. The other thing people always ask who come to train with us, they want to, have you ever had a perforation? Well, I guess we could knock on wood, but it's not my answer, but it's the company's answer, almost unheard of. The device is very, very safe, hundreds of thousands of applications, and that has not happened. Now, part of that in the design, I won't bore you with details, but the device ramps down the energy with when it runs into certain resistance, certain power delivery is performed a certain amount of time. There's also cooling that we use. There's the window in the pericardium. When you finish, that's what you got. You got that little incision, and you got the little drain. And again, we give thanks to Bill Bodefeld, who's a young, excellent cardiac surgeon, and Ken Savello is a colleague of Dr. McKinney. These guys, I really think, are their program and ours, I think, we have the largest volume in the world. But Bodefeld and Savello really led the charge on this. And I always like to throw out Savello, who graduated from Grace King High School. So that's kind of interesting. I want to see if I have the company propaganda film is a little easier to digest. Here's the mannequin, and there's the cannula that goes into the heart sac. And that's the back of the left atrium. And there's the device, 3 centimeters long, just over about 1.5 inches. And they show it as though they're shooting lasers out of it, but they actually have to touch the heart with it. We just step on a pedal. It takes 90 seconds for each of these burns. So we usually have to find something to talk about. And we move to the next spot. There are some other lines that we do that we talked about, but I think those details are not really important here. There's a lot of the stuff that was done early on. Really, Dr. McKinney can do that so much better during his part of the procedure. But this is the surgery part. This one big hole. And once this is finished, we put a small drain that stays while you're in the hospital. We close the incision in the middle. And then this is Dr. McKinney. I'm done, I walk away. He goes up through a vein into the heart. And this is oversimplistic because he does a lot more than this now. You can think of this as sort of like spot welding. But we are now using, I say we, he is using the cryo balloon. I would say the majority of cases. I don't have any pictures of that, but he certainly has a number of talks he's given on cryo balloon. If you catch another support meeting, I'm sure he'll show you. The cryo balloon is something that can be taken to a very, very cold temperature. It's blown up and it sits against these veins, and it winds up giving you an elliptical or a circular burn, if you will. A burn is kind of like sticking your tongue on a frozen pole, for those of you who live north of New Orleans anyway. Where I grew up, you could stick your tongue on a pole and you're in deep trouble. That was the next movie. Now, talk about results. The European Consortium published data that's very similar to what's on the screen. People got to somewhere around 100 cases and they wanted to report the data. And I think what we tell people, what I tell them, if you want to think of it, you'll get a lot of percentages and statistics. Probably at around 2 years, if you look at a crowd of any 100 patients with the hybrid convergent procedure, we cure about 3/4 of them. If you're really lucky, you might get to that 82% number. The Carolina group, back a few years, Kaiser published data very similar to that. So for one thing, the results seem to be similar in dissimilar institutions by different people doing slightly different things, but the concept of the surgeon doing the box and the electrophysiologist moving the catheter up and doing what it is magic from the inside. Now, so They reported Cervelo and Vodafil on their 100 patients. Again, they're well north now, somewhere around 350 or 375, I believe. And I think if you talk to Cervelo recently, they're getting about the same traction out of the procedure. And this is actually a scientific paper, so I'm not going to bore you with details, but when I squint and look down at the numbers, they're somewhere close to the bottom. It says at 12 months of follow-up, 87.5% of these patients were in sinus rhythm, with or without drugs. Now, I'm going to get back to that in a minute. They had no bad complications. They list a bunch of stuff here that, you know, heart attack and esophageal injury and deaths and all that stuff. Nothing. None. We've been also very fortunate. We have not had any catastrophic events occur, which have been a problem historically. Again, if you just go in there with a catheter and start burning around, it's just, some of it is very dangerous for the catheter doctor, and surgery has taken some of that danger away because we do a part of it that we're looking at under direct vision. And if you remember the device that's doing the burning, we're looking away from all the bad stuff. We're looking at the heart. We always see it. And of course, that's something that's not true. If you're in a catheter-based procedure, you are relying on the technology of radar and three-dimensional things and CAT scans and a lot of experience. I'm almost closing on this, and I think right on time, but this might prompt some discussion with Dr. McKinney. But one thing I always like to tell people, when you talk about success, you notice that line down there says 87 point whatever % success on or off drugs. And you might say, well, I want to get off the drugs, that's why I'm doing this. Well, not necessarily. Most people want to be out of atrial fib. And we think that folks that may be on some drugs at some period of time after all this is done are not necessarily failures. If you talk to the people who can run around and play with their grandkids and not be exhausted and feel their heart in their throat, or if you talk to folks that don't take a nap in the afternoon anymore, or people that wouldn't dare set foot in Walmart and try to get lost and shop in there for a couple of hours and then walk back to the car, and they now can do that, and maybe they're on a lesser expensive drug, maybe they're on fewer drugs, maybe they're on one or two of the real dangerous drugs, then I think we have success. Now, is that going to be true, as I started out this conversation? Is that going to be true 20 years from now, 15 years from now? We don't really know. There's one other quote, I'm quoting Jim, and I can't remember the study. There was a group last year who reported hybrid convergent maze, small group, 40 plus patients, Jim, 100% success in 1 year.
With loop recorders.
Where?
They had loop recorders too to prove it.
The reveal links.
Yes. That's a good thing too. You know, back in the old days, we just, in the time of Jim Cox, monitoring was really a nightmare. And if any of you, I mean, I wore a Holter monitor once. That's incredibly difficult. It's sticky things all over you. And the boxes back then were real big. I know they're smaller now. But Dr. McKinney and Dr. Zhao now have a Medtronic device that looks like it's about the size of a stick of dentine chewing gum. You make a little slit in the skin and you just almost flip it in there and close it. And it gives you 3 years of data.
Almost 4.
For 24 hours a day. Never any question whether you're in AFib or not, or when you were, or how many beats you had. I'm fond of telling patients, insurance or not, I'm going to sell bottle caps or something. I'm going to buy one. When I go into AFib, I'm going to get one. That's the first thing I want to do, so I can tell what I'm doing, what I'm treating. But this is encouraging. This is published data. We think more will come out. The vendors are going pretty crazy about this. We're training teams almost on a weekly basis now from far, far away places, and we're very proud of that. I think the conclusion of all of this is that We know with temporary on and off atrial fibrillation, Dr. McKinney and Dr. Zhao can do a great job of that by themselves. The surgeons are no longer really needed to take care of on and off, once in a while, atrial fib. Their technology is so good that it really doesn't make sense to try to do the old surgery procedure for that. On the other hand, I got this 40% from Jim, so you can correct me if you think it needs to be changed, but people that have atrial fib all the time or have had it for a long, long time, certainly people out 4 or 5 years, 10 years, the results of he and Dr. Zhao can try all day long in the lab and come back 2 or 3 times. It's just poor. It's just not cost effective. You've got the danger and risk with it. And if you look at a comparison with the Convergent Maze, combined with the surgeon, the kind of results you've just seen a few minutes ago, it doesn't make sense to even try it. But there's centers in the country that still do that. They believe in it. That's what they're doing. But we think the technology is going to overtake them. And based on what we've seen in just the last 6 months, I believe it's going to be a turnaround. That's really the end of the last slide. Just have that area ablation up. It is 7:29, and so I'll stop here and see if you guys have any questions, and whether Dr. McKinney wants to comment or throw me out. Or
So let's open up to questions, and we can, yes, sir.
Is it less likely that a stroke takes place? Wasn't that a danger in the past during the?
Yeah, there is a, you know, we've tightened up the anticoagulation. There have been a couple strokes with the procedure, but you got to remember, we've done now over 200 patients.
2:30.
230. In fact, we have a pre-med student right now working in our office putting this data together. There's a stroke risk that's substantial whether you have the procedure or not. So 2 or 3 out of 230 is actually less than the anticipated stroke rate of AFib. The trouble with the procedure is that the stroke risk comes up front, whereas if you have AFib, the stroke risk is distributed over time. Stroke with AFib is a big problem. The old mini maze, what Mike called the mini maze, where you go through the chest here, one advantage of that is that you did clip off the appendage, which we don't do with the hybrid convergent procedure.
Let me mention too, with the atrial appendage, he just mentioned that we did that. Remember I told you about safety. Resecting the atrial appendage in the mini maze during the left-sided procedure is not without risk. We were very fortunate, or maybe as they said, as Jim said earlier, I'm just so picky, I get so slow I can't stand myself at times, but I'm very compulsive. We were lucky. I did hundreds of those cases, never had a problem. I will tell you that some of the finest surgeons in the world had 1 or 2 deaths related to the atrial appendage, and they died quickly, immediately. You lose control of the left atrial appendage, you're in deep, you know what. So it's a trade-off. And as I said, the wise man said, if we can maintain a sinus rhythm, why not keep your appendage like everybody else? Now, let me make one comment about stroke with the procedure. Our stroke rate has diminished. It was higher in the first 100 cases. As Jim mentioned, we got real aggressive with anticoagulation, and we are still very aggressive with it. It has declined drastically, and I'm hoping over time, all the people that we had strokes with recovered functionality. Even the worst one we had actually is completely normal today. We did have one early gentleman with a little visual defect which affected him in driving, and that's never gotten better. That's 230 patients. The stroke rate has diminished to where I put on the consent now it's 2 to 2.5%. Now, if you have atrial fib, I don't care if it's continuous or not. If you're in and out of it, some people think the risk may even be greater because you're cycling back to this contracting atrium, which can squeeze the clot out. If you take a tube of toothpaste and loosen the cap, put it on the floor and step on it, you could probably shoot the stuff across the room. And that's the mechanism behind clots being ejected from the atrial appendage. But let's go back to atrial fib. If it's intermittent, if it's all the time, your risk of stroke every day that you live, if you look over a period of the year, is about 4 to 6%. Coumadin reduces that risk. It does not eliminate the risk. So every year you live with atrial fib, it might be small, but you have a cumulative risk. Now let's live 10 years with atrial fib. Now you're talking about some numbers that are getting up there. You might be on Xarelto, you may be on Pradaxa, you might be on Eliquis. I don't know what some of these new drugs are going to pan out. They have their own risk, and some of them are very expensive. So if your risk of stroke over 10 years, you do 2%, 3% multiplied by 10, now you're up to 20%. So we're going to tell you you can take a procedure that has a 2.5% risk right up front. And oh, by the way, if we get you in sinus rhythm, then you're free of that risk as long as you stay in sinus rhythm. Atrial appendage becomes a little bit of a moot point, but it's also, it's a dangerous area to work with, and it's not going to be widely done by surgeons. There are some catheter approaches to that appendage that are becoming, there's a lot of interest in that even in this institution. There are devices that are coming along. There'll probably be some other approach to the appendage. But again, going back to Jim Cox, the one way to handle the appendage is with the Cox Maze.
You know, we've had, over my 30 years of doing this, we've had about a dozen patients who have either you've done or Jim Cox has done. They're all fixed. I mean, I've never seen a recurrence after Cox Maze. How many people want to have the chest sawed open and do it? That's a different thing. Very few, but for example, we've had patients who were so incapacitated. A couple of them were traveling salespeople who got tired of going to foreign, going to emergency rooms in different states. They said, "I can't take this anymore. My career is ruined. I gotta be fixed." So are there people who will put themselves through that? I mean, we don't recommend it as a. In fact, when I sit across from most patients, I go through the litany of what we can do, and we call it a decision table. I've gone over it with you a few times. If you have Afib, you can do nothing and live with it, and live with the symptoms and just take blood thinners. Or you can take pills and then go through cycles of shocking the heart and readjusting the pills. Or you can have a procedure done through the leg alone, or you can have a procedure done through the chest in some variation. We use this procedure, hybrid convergent, but that's basically it. That's the whole decision table that we can offer. We don't have a magic bullet that we can use medically. Drugs, as you know, how many have taken antiarrhythmic drugs for Afib? I mean, I'd say almost everybody has taken some drug for Afib. If we had a good drug, we wouldn't be using any procedures.
And the best drug that we have ever is the most dangerous drug that you could possibly use. It's a mockingbird. It can do anything. And you may be very lucky and nothing ever happens. And you may take it for 2 weeks and wind up with a fatal complication. It was the first drug and only drug approved for atrial fibrillation for a gazillion years in the last century. As I said in the beginning, there was no cure. We still didn't cure anybody until Jim Cox proved that could be done in the laboratory.
What was that drug, Doc? Is that amiodarone?
Amiodarone.
It can be a very dangerous drug. You have to be monitored quite a bit for it. Most patients do well with it, but there's the unpredictable, like everything in medicine. I always tell patients, how many have heard my spiel that medicine is great at telling you what happens to 100 people? It's lousy at telling you what's going to happen to you.
That's called statistics.
It's called statistics, but you're not a statistic.
By the way, incidentally, amiodarone, I want to give it some kudos. In heart surgery and cardiology, it is one of the safest drugs we've ever used in very, very bad hearts that are weak, barely pumping, and have to have devices to support them, and bad valves and bad coronaries. You can give it, the heart tolerates it well. It's a paradox to me. It's such a wonderful drug. It's a lifesaver, and the best thing was ever done for atrial fib. It just has a black box warning that can bite some people. It's not going to hurt everybody.
Yes, sir, you had a question.
Do the patients that don't have the stroke with the procedure that you're talking about, do they get off anticoag if they go into normal sound rhythm?
It's a great question. The majority of my patients who maintain normal rhythm for 6 months particularly if I have a link recorder in to know if they're having recurrence, I try to get them off the anticoagulants.
So all the
That's a
patients
very
that have this
controversial-
procedure get this recorder, so you
Not
know for
everybody,
sure
some-
that they're not having
It's
episodes of AFib?
I think it's the best way to do it. All my doctors who have AFib want it, but I don't push patients to have it. We offer it, but we tell them the advantages. We don't push them to have that done. I think it's better because the monitoring is more of a pain in the butt, and over the cost of a follow-up, the cost is much more having multiple monitors than having that simple device. It's actually smaller than a piece of chewing gum. It's about the size of a paperclip. That's the best way to monitor.
Does most insurances cover that?
Most do. Because they know it's cost effective. They'd rather pay
There's
for
some
that.
restraints on it, but they seem to be getting around it.
How long does this operation, the hybrid one, take?
We always kid patients. This is a procedure where we take everything we know about fixing AFib and we throw it into the gumbo. His part is particularly predictable because he's got his routine down to a science. And usually he'll start his procedure about 8 in the morning, and by about 10 o'clock, 10:30, they're calling us to go up and do our part of it. We, on the other hand, tend to do a lot of other things. We do vein isolation. If we see what we call atypical flutters, we'll go chase a lot of stuff to try to fix AFib. So typically our procedures are ending anywhere from, if he starts at 8 in the morning, we're finishing anywhere from 2 to 4 in the afternoon. That's a long procedure.
Incidentally, one of the first things they do is look at everything I just did, because they have the capability of looking at that with all their.
Who is really the ideal patient with AFib for this procedure?
That's another great question, because not everybody who has AFib needs procedures. Let me give you an example. If you're not very active and you have no symptoms, you have completely asymptomatic AFib, there's a big controversy about whether you should do anything. The majority of our patients, it's affecting their quality of life. The overwhelming majority of our patients, they're very symptomatic with it. They can't do what they used to do. The medicines are dragging them out. They feel like crap for the most part.
Right.
The majority of our patients. We almost never take anybody asymptomatic. There's a lot of stuff in the literature now. I'm not going to go into a lot of detail, but there's a concern with AFib. You know, Mike said earlier that AFib's not known to kill anybody, although patients with AFib tend to live less long in many cases. And one of the mechanisms for that may be that instead of having the big stroke that brings someone to the operating room, when you're in AFib, you may be throwing these little bitty micro strokes. Okay? And so there's a lot of data, for example, that shows that the risk of Alzheimer's or dementia is higher if you have AFib, whether you're anticoagulated or not. So there's a whole big new area of research in AFib about what does AFib do to the brain. So even if you have no symptoms, so that's an aside. But who's an ideal candidate? Someone who's failed drugs, who has symptoms that are disrupting their lifestyle, and who are willing to undergo an educated assessment of risk and benefit.
What did you mean by not very active? You said the patient is not very active, and then you went on to say,
Well,
taking drugs makes them feel bad.
One of the things AFib does is it robs you of exercise capacity.
Say that again.
It robs you of exercise capacity.
Oh.
You have one way to think about what the upper chamber does. It's like a turbocharger for the lower chamber. When you lose its function, when it quivers, you don't get that booster effect, and so you don't tend to be able to do what you could do. If you go up 3 flights of stairs in this period of time, you go up maybe half that. Everybody's different.
So the people that are failing the procedure, have they been looked at and anything identified in those people that
fail this procedure?
Yeah,
Because there's a
right.
20%, roughly 20% plus failure rate. There's not been good studies on what happens to those patients.
or why they failed or any?
That's the big question. Why do they fail? Because theoretically, you're attacking the back wall of the heart where most of the AFib lives. And when you look at what he's done, the first thing we do after Dr. Brothers is finished is we go into that chamber, and with a circular mapping catheter, we move it all around and we look and see what the voltage is. And at the areas where he's applied his energy, the voltage is almost zero. That means he's been effective. But why we have recurrence is a big question mark.
It looks like to me, Mike, that it's difficult for you to see the tip of that thing that does the burning. You know, do you know that you're all the way across that box, or, you know?
The nice thing about it, if you know, the pericardial reflection at north is complete all the way across the vein. So when you push the catheter up,
I see you.
it's going to stop.
Bump, yeah.
It
okay.
stops by the
Right.
tenting of that. Now, you can't be cowboy enough that you push it so it curls up and disappears. That's where part of the skill is. But you want to, that is the top end, and it also corresponds to what is known as the roof of the atrium. That's really very easy. We've never seen anybody with an incomplete, you have to work to get that down when you're doing other types of heart surgery. Let me mention something else about AFib. One of the things that's a big risk factor, and probably a bigger problem in our society as years go by, is sleep apnea. And that's a poorly understood correlation of what the mechanism is. But you probably know sleep apnea is a higher risk of sudden death. There are a lot of different medical problems that develop with sleep apnea besides fatigue. One of the leading causes of death with sleep apnea are highway accidents. Not because you're driving in your sleep, but because people are tired and they fall asleep at the stoplight and they have poor judgment in operating a vehicle. But we also know that there is a very strong association with sleep apnea and atrial fibrillation. And a lot of times, Jim and through the sleep study folks will actually get people evaluated for sleep apnea if they have not already done so.
Our typical patient would be someone referred from cardiologists who've been taking care of a patient for a period of time, and they failed every medicine. They've been shocked on average 2, 3, 4 times. They keep coming back. Their quality of life is poor. They can't tolerate the medicines. And so by the time a patient comes to us, they almost want us to go try something. That's our typical patient. Now, early on in his experience, he didn't mention it, but one of the reasons we wanted to get into this was because we got tired of what the old way of doing it was, where the catheter-based doctor would do this 1 time, and then 2 times, and then 3 times, and I said, this is ridiculous. I said, this is absolutely idiocy to keep doing the same thing over and over again. And so our approach nowadays, if you failed a catheter-based procedure, you go right to his procedure, or our procedure. We don't do these. I mean, there's big centers in this country that will do this 4, 5, 6. I mean, there's a center in Houston that will do this 6, 7 times. You know, I mean, that's ridiculous. That's crazy. So when patients ask me what's the biggest downside of all this, the biggest downside is that we put you through it and the thing just don't work. We don't have a surgeon goes in and takes out your gallbladder, he can almost guarantee he's coming up with the gallbladder. You go in with this, there's more uncertainty. There is the possibility of failure.
When are they coming up with an antidote to Xarelto? Change the subject slightly, but
Well, we have an antidote to Redaxa. It's called Praxbine. It's going to be in the pharmacy here very soon. It's already in.
Does it work?
Yeah. Oh, it works very effectively. The Xarelto antidote is actually, we're not supposed to advertise it, but there is activated prothrombin complex C in the blood bank. That's probably a good antidote, but the specific antidote, I'm told, I don't want to overpromise, but I'm told should be out within the next 4 to 6 months.
We apologize because you have an experienced physician in the audience asking these questions. So all this,
well, but
all
he has
this,
atrial
all this
fib,
went
so.
over, yeah, but all this went over your head is 2 doctors talking now. And but we appreciate that question.
Yeah.
Any relationship between AFib and PVCs?
Well, yes and no, because a lot of times patients who have atrial fibrillation have some type of structural heart disease. It's usually hypertensive heart disease, where there's diastolic dysfunction of the heart, and those patients are prone to have more PVCs. So there's not a causal link, but there's an associative link. They can exist as totally separate problems.
More often, I think when I talk to people that you see, I'm not an electrophysiologist, but you usually see people that have PVC problems or ventricular tachycardia and that sort of problem, or they have atrial fibrillation. We don't usually see a lot of people that have both as a big problem. Is that fair to say? Because ventricular atrophy can be a really troublesome problem, and if you have coronary disease or organic heart disease with it, then it's dangerous. Some atrophy in the ventricle is not necessarily even dangerous.
Right, most of it's not dangerous. It just aggravates you.
And by the way, we have to, one of the things, I think good questions about when you do this and how people feel. The people are really developing suddenly at this, in our age group in life, and you start developing shortness of breath and discomfort and you're tired. There's a certain amount of ruling out stuff that you got to do. You need to make sure if you have someone that's not developing lung disease, you need to make sure that the referring cardiologist is willing to do maybe a nuclear study or a treadmill, maybe even a cardiac cath. We've had some people that we have evaluated all the way up to the door looking at possible hybrid convergent maze and stopped the train because they have clinically significant coronary disease and they need a stent, or they need bypass surgery, or they need to have their idiopathic lung fibrosis treated, or they need to stop smoking, or maybe they need to lose a lot of weight. So it is important for us to not just willy-nilly take everybody who walks in the door with atrial fib, but I think we're doing a pretty good job.
It's also important to realize that once there's been surgery on the chest, Mike's options are limited. Once you've had surgery in the chest, there's a scarring reaction that makes it very difficult for him to go in and do what he needs to do. Prior bypass surgery, for example, pretty much means you can't have a hybrid convergent. In fact, some abdominal surgeries where there's dense adhesions, Mike can go over the list of who he would not operate on. You want to go over that list?
Well, unfortunately, the patients you've been sending me, we've done a lot of patients with lap bands and gastric bypass and colectomies and splenectomies, and we've been working around them pretty good. We haven't had too many with
chest surgery. Chest surgery.
Oh, chest surgery, yes. We did do as far as we know, talking with the company about 2 months ago, I did do one patient. The first hybrid convergent maze in the world. It was done in a patient with previous 3-vessel coronary bypass. It was very successful. Several weeks ago, I attempted the second such operation in the world, and I aborted. I backed out. It was very safe, but I couldn't do it. So it just tells you how difficult that is. We're not recommending any of our training centers, any novice, try to do anything with someone who's really had a complicated abdomen or a complicated intrapericardial problem. Pericarditis, for instance, we had a gentleman in his childhood who had pericarditis. We didn't get the whole story until after the procedure, but it was impossible to do the case. We just couldn't even get a plane. Now, in that case, another nice thing about the hybrid setup, though, in that case, I back out, I call Jim and say, hey, what do you want to do? I can't get there. And I'll be right up, and they move on with a catheter-based solution. And at least it's better than doing nothing.
See, part of the problem is it's a very poor, even though atrial fibrillation has been studied with the best techniques available, unraveling what's happening during AFib is very, very difficult. And some of the best minds in medicine have tackled it. We don't have a good understanding of what is actually happening to the upper chamber when it's fibrillating. We can record all the electrical activity, but piecing it together is difficult. So if we had the holy grail of knowing what's driving it, we could go attack that area, but we've not found that holy grail. So most of our procedures are anatomic based on where, we know certain lesion sets tend to work, but we don't always even know why. So until we get that understanding, we're not going to have a procedure that works 100% of the time.
Dr. Cox never wanted anybody to vary the lesion set. It was established, of course, with less than 1,000 cases, and I don't know how much laboratory work. He was adamant. He didn't change anything. People go, oh, we do this, why don't we do that? No, that's not demonstrated. This is proven, and to some extent it was a little bit empirical and anecdotal, but he built that spaceship. It flew and was reproducible, and he won't hear of anything that's a bastardization, so to speak, of that procedure. That's just how it came about.
You know, it's amazing. I think in your first 15 or 20, we sent you 3 patients who had been in AFib for 10 years. Where everybody else had given up on them. They were virtually cripples because they couldn't do anything. And I wouldn't have sent them to you unless they were that symptomatic. And all 3 of those patients, after 10 years of AFib, which was felt to be no man's land, were in normal rhythm a year later, which is unbelievable. That's when I became a believer, a real believer in the procedure. But then again, we'll sit across from somebody who should have had a good result, and you know, a year later we're struggling to keep normal rhythm. So there's a lot of unknowns in all this. So I don't want you to believe that we know everything about AFib. We don't. Our ideal patient, our standard patient, would be somebody who's very symptomatic, who's failed drugs, and wants to accept the small risk. Yes, sir.
Vice versa, is there any scarring from this procedure that would prevent other procedures that may need to happen in the future?
So
That's a real good question.
yeah, I'll let Mike handle that.
I will tell you, with this procedure, it has been really unexpected to me. It was a godsend because we've done some other operations on people with the hybrid convergent maze, and it has not been very difficult. We even see this little hole in the diaphragm. The liver is sealed up against it. It has not been a big deal. What has been the most difficult thing I could ever do, the hardest case I ever did in my life was only about 4 years ago, was a bilateral thoracoscopic procedure. Remember procedure number 2? We had done years and years ago. Actually, I didn't do that. Jim Pygott did this case, and he did a good job. I mean, he did a bilateral thoracoscopic maze by the book. Young man, very symptomatic. I mean young, talking about 40s. And we all talked about it, and we decided he was going to have a full Cox Maze. And we cured him. I'll give you the end of the story first. That was the hardest case I think I've done in years. I mean, it was all day long. It was stuck like concrete. You couldn't tell where anything was. I had to get really on my hands and knees and slow down to a crawl to do the case. So this procedure, we have not seen, but a few people that have been operated on. Emergency coronary bypass was one of my partners did. There's been another case where I did some additional procedure. We could do a Cox Maze on a patient like this. It failed. Not very bad. See, opening the pericardium on the side and going through the chest and leaving the atria exposed, big openings and a lot of inflammation that occurred with the thoracoscopic mini maze. That was an eye-opener for me. I'm not sure. I'd have to be, I don't know what you'd have to do to get me to do another patient who had had the legacy mini maze through the chest, through a sternotomy. This procedure, the nice thing about it, I think your question is really a very, very good one, because one of the things everybody's asked tonight, well, what do you do if this fails? What do I do to get more medicine? Do I get another ablation? Well, a Cox Maze is possible, and a coronary bypass or valve replacement is possible, because it's a different area than we would be working on. So I think it's very possible to do that.
You know, one of the things that I had one of my partners at Tulane, a doctor friend of mine, have the old procedure too, mini maze, and you know, you got to realize that once you put something through that rib cage, it hurts like hell the next day. This little incision here that he makes, patients sail through that. But that when they go through the rib cage like that, that hurt when they woke up. We did a lot of them. We did 100 of them at least at Tulane, and we got good fix rates. But I think this is much better for patients. I think the Convergent's much better.
One of the problems we've had with this is actually once people, a couple of days. We used to do a couple of days in the hospital. We didn't talk about that, did we? But we spend the night in the ICU. Everybody usually gets to sit up, have something to eat. We send them to the floor on the next day. Our pathway was usually we do these on Tuesday, and by Thursday afternoon we were sending them home. We had more people that were local, but the problem we're having now is that Jim has patients come from the Gulf Coast, or they come from Lake Charles or Monroe. We had a patient from Arkansas. We can't put those people in a car, get them on a highway at Thursday night, certainly in the wintertime. So we tend to have dragging out now to 3 or 4 days, and it just, whatever makes it easy. but patients feel very, very well. That's one of the problems. We're having the opposite problem. Instead of all this pain, they're very comfortable. They go out, and we've got a small hernia rate with this incision here. And it's very hard to combat. And Bill Bodefeld and I both have anguished over it. We try to, in the very beginning, we realized we had young bucks that were going out, going back to the gym and doing sit-ups and push-ups. And we thought, oh God, we didn't think of that. You know, we tell people, oh, once you get back to your regular activity, well, I thought, you know, on the computer, you know, on the phone.
I have a
No,
question.
you're out doing heavy stuff.
Do you always do both procedures, and how long, if so, how long?
We
have
work
you
as a
been-
team. We think that's better. We have a beautiful hybrid room that we can get everything done. Again, Mike will start in the morning. We usually triple team. It's a long procedure, so Dr. Zhao will come. Dr. Brothers starts, I do the middle part, and Dr. Zhao does the last part. I mean, I finished one yesterday. We finished early because everything just fell into place, and you turned it over to me around 10 o'clock, and I think it was finished by 1:30.
Yeah, that was very good, reminiscent of the old days.
And we're beginning to believe that, you know, sometimes you got to know when sometimes we get trapped into maybe chasing too many things because we frankly don't know all of the right answers. But, you know, just doing a simple convergent followed by the cryo balloon right after it, we've gotten very good success rates. In fact, the Tampa group with 40 patients reported 100%. I can't believe anything works 100%, but they had the data to prove it, so I have to believe it. So, procedure can be done as quickly in about 4 or 5 hours.
And the recovery time.
Well, that's what I mentioned, in 2 or 3 days, you go home. I mean,
But back to work, or back to the gym?
well, it depends on the work too, as I just said. You know, we've had attorneys in the hospital dictating and on the computer before they even go home. If you run your own business, you call your own shots, you show up, you stay if you feel like. If you don't, you go home. The problem we have is that we had a diesel mechanic at one of the local beverage bottling companies, and they change these big truck tires, and he uses a wrench 5 feet long. You can't do that in the first 6 weeks. You're going to get a hernia. If you're just a die-hard golfer, I tell people you just can't swing Big Bertha the first 6 weeks. You feel great, but you're going to get a hernia in this incision if you overdo it. And I think with people in the old days when we did a lot of abdominal surgery, open aneurysms and gallbladders and colons and all that. This is what people do for 6 weeks. They walk
How
around.
often on a weekly basis?
With this small incision, people don't do that.
I'm sorry?
How often on a weekly basis do you all perform this procedure?
Our big day is Tuesday, and when we get too big a backlog, we'll go Wednesday. But Mike's right. One of the points is that most people don't realize if you're in persistent AFib, you don't realize how bad you are until you get put back in a normal rhythm. Your body's acclimated to feeling bad, and then you get this surge of energy when you're back in normal rhythm, and you feel like you want to go out and conquer the world, and then you go out and swing the golf club, and you get this little hernia right here, which then needs to be fixed. But so Tuesdays and Wednesdays are the days we tend to operate.
And you do 2 separate procedures. You do your procedure without his procedure.
No, we do them always together. Okay, so our procedure, the way we approach AFib is very simple. If you have come and go AFib, we call it paroxysmal. We think that's best approached, although it's debatable right now. We think that's best approached by simply going through the leg, and we use the cryo balloon technology.
That's what I have. I have that in and out stuff.
So in and out, I had a guy today who was repetitively having bursts of AFib. I put the freezing balloon at the left bottom vein. I froze an area, it went completely away. That's beautiful. So the come and go AFib, we tend to use a leg only approach. If you have the persistent type of AFib, we almost never use that approach. We've come to believe that it's better to do one bigger procedure and give you best chance of getting a normal rhythm than doing 2 or 3 smaller procedures.
And the post-op, and I've had a problem with this at an old angiogram. Well, the vessel was lost, and I had a huge hematoma and all that stuff with the blood poured in. And I just had a friend of mine went through the same nightmare in the vein,
It can happen.
and he had a real nightmare. Before they caught it, he had to give him 2 pints of blood and all of that kind of stuff. I mean, how often does that happen?
how often does a big hematoma happen?
I mean, I had a huge hematoma, it was.
But that's for an arterial stick. We're not going into the arterial system.
My friend had a vein thing.
But a vein procedure can be bad too. You can
Yeah.
develop you can develop a fistula. I'd say it happens about 1%.
The question I always, I've had 4 angiograms, and I always tell them that I would prefer the cath lab dude or gal to come up and just sit there with me for about a half an hour. I'll pay for the extra time.
Yeah, they can do
And
radio
put the
right
hand
now.
pressure on the thing
Yeah, they
versus
could-
some other mechanical device, which didn't work for me.
The radial, for you, radial approach may be better. They can do it through the wrist now. They don't need to go through your leg
Yeah.
anymore. In Europe, they're doing that 100%. They've abandoned the leg approach. Because
Our
this is safer.
cardiologists are doing radials, many of them now, it's becoming the trend to go through this little tiny artery. I don't know how they do that, but they do.
But you're right, a venous bleed can be pretty bad.
Yeah.
It can be.
And we make all that, possible because I just got through telling you earlier that we pour on all these anticoagulants because Jim is fond of saying bleeding is bad, but strokes are worse.
Right.
So we take a little bit of shift in that curve to one side.
But you said about 6 months for you to determine if the ablation has worked or not, whether you feel comfortable with that.
So there's a couple components to that. After Mike lays down his lesion set, that area has to heal a certain way.
Mhm.
And then when we lay down our lesion, that area has to heal a certain way. So you have to heal with what's called a homogeneous scar. If the scar is incomplete or there are breaks in it, it doesn't work as well. So typically that process will take 4 to 6 weeks for the heart to physically heal. So we don't start counting the results really until after that. But I'd say by 12 weeks, we're starting to make decisions, 12 to 16 weeks about blood thinners and antiarrhythmics. We always stop the antiarrhythmic first because in case you went back into AFib, we want the backup protection of the blood thinner.
How long does it take you to typically get off of the antiarrhythmic drug?
Usually 2 months, 1 to 2 months.
I'm taking that nightmare stuff so long, good lord.
Sotalol is actually one, they're all, it's actually one of the milder ones.
I disagree, Doc.
Let me mention one thing about the arrhythmia right after the procedure, because your question brings this to mind. A really important thing, we spent a lot of time with our staff, operating room, certainly telemetry people, nurses on the floor, and believe it or not, our referring doctors, because what happened, the reason there was so much time between the very first patient that Dr. Cox did after all the work in the laboratory. First patient in the whole world was a Greek airline pilot, and he followed Dr. Cox around. He begged him. He had the airline privileges, so he flew him. Everywhere he could find him, he was, I got to have this operation. He said, we're not ready yet. We're not ready yet. Investigational board hadn't approved it. He was still doing primate studies. Finally, he convinced him to do the Cox Maze on him. First patient in the whole world. So they did this complicated operation they'd done in animals, and he looked fabulous. And they were all patting each other in the back. I could see confetti and party hats and champagne. And so about 3 or 4 days later, somebody came up to the office and told him, Dr. Cox, this guy's an atrial fib again. They were devastated. The team was devastated. Dr. Cox was devastated. It looked like, I could imagine something out of one of these movies, about the heroes and the Saipan Death March. Now, Jim Cox told me this story. I've heard this story, like one-on-one sitting at a table. They didn't do another case for over a year and a half. One of the cardiologists on the staff came to him later on in 3 or 4 months and said, that guy that had the atrial fib, well, it went away again. And then it came back. And as time went on, beyond about 3 or 4 months, he was in a sinus rhythm, and he stayed in the sinus rhythm the rest of his life. And so, I don't know exactly what happened during that time period, because then he did another nearly 700 cases in his career. But the thing we tell everybody now, it's true today, it's true with the Cox Maze, it's true with the hybrid maze, it's true with any type of ablation. Certainly the Cox Maze, 2/3 of patients will have fast heart rates, atrial fib, atrial flutter, immediately, continuously, or not at all in the first 60 to 90 days following the procedure. So much so that the major societies that Jim belongs to, the Heart Rhythm Society, they won't recognize even any data. You don't report anything in the first 90 days. In fact, the majority of patients will have arrhythmia. And we'll often do this procedure now, and our staff is ho-hum. We'll do the procedure, we get them in sinus rhythm, we get them on their medicine. It's Thursday night, we're getting ready to send them home, and they go into atrial fib. And we just tell them, okay, we're in atrial fib, you're going to see Jim next week. And we'll, you know, most people pop in and out of it. Some people get cardioverted if you want to be aggressive. But if you have this procedure, you may have atrial fib even before you get out the back door. And we used to, staff used to cry, oh God, this didn't work, it was a failure, oh my God, Dr. Brothers, you gotta come see. No.
It definitely takes time. It takes 2 to 3 months for full healing.
One last stupid question. I am a member of a wine tasting organization, and I have not touched alcohol in about 3 months, or very, very little. If you go through this procedure, you get off some of the drugs, can you go back to sipping a glass of wine or something?
A glass or a bottle?
I'm not gonna go there, Doc.
I get asked that question a lot. One guy came to me and said, look, I like, you know, I party a lot. I got to get rid of this Afib because it puts me, when I go drinking, it puts me in Afib. I got to get rid of it so I can go drink.
Right.
So I'm not supposed to offer you that kind of advice, but there's been no studies because we know alcohol can trigger Afib.
Right.
But, you know, believe it or not, I'm not aware of a study that's looked at alcohol patterns after to see if it makes it worse. I don't know.
Another way I look at that, at least as I get older, you know, life really is, you only go around once.
Right, exactly.
And it's not that long. So we're trying to make a balance with quality of life, hopefully pain-free. You know, you gotta, when I was younger, I used to be hammering on patients about what they do and what they don't do. And I couldn't figure out why old people with gray hair and no hair would be look at me and just, yeah, okay, thank you, doctor. Now I know why. There are just some things, you just do the best you can. And if, you know, a lot of things you don't do anymore, you can't do anymore, you can't see, you can't play golf, you can't get out, do this, that, the other. And I won't mention some of the things you might not do as well as you used to. You need to, if you want to do something that makes you feel good, moderation, I mean, you might take that risk.
I personally don't restrict wine drinking after. You get that question a lot. You know, there's been a lot of studies, moderate red wine consumption is very beneficial. So I don't restrict it.
I'm a big believer, except that I'm very cautious lately.
I think we're going to summarize here in a second. So Mike's done a beautifully nice job of historically taking you through where it started, where we are. If you go to a different institution, they have different bias, different perspective. And the reason is because until all of this stuff is subjected to a huge randomized trial, right now there's no quote answer. We have our approach. We think it's a good approach. If you go to Austria, they have a slightly different approach, not that far off from ours, but slightly different. If you go to Our Lady of the Lake, they have our approach. It's basically the same. If you go to Stanford, it's going to be slightly different. I am a little leery. I am critical about my own contemporaries who keep doing the same thing over and over. I think if you've got 5 years of persistent Afib, I don't think going through the leg vein multiple times is the best approach. I think that's frankly stupid. It's good for the institution's volumes, but it's not good for patients. But those people believe that. It's not that they do it just to make a buck. They believe it. They believe that's the approach. That's the best way. They're not dishonest people. They're honest people, but you know, we have differences of opinion with them. So the majority of people you meet with this field are going to admit that they're very humbled by our lack of being able to provide something that works 100% of the time. So we're never against other opinions. You know, if you want other opinions, we can send you to a number of people to second opinions. But there is no consensus, no global consensus about if you have A, B, C, you got to have, you know, D, E, F. That's the trouble. So I hope this is going to be recorded. If you want to get on the website and go back and look at some stuff, look at these beautiful pictures that Dr. Brothers showed. We are compiling our data. Dr. Zhao let me down. He's in London right now. But we have a student putting all of our data together, and we're going to, at this support group, we're going to unveil that data once he shows it to me. We think we're getting very high success rates, but until you actually look at the numbers, you can be biased. I think within the next 3 months, I can actually show you of the 230 patients who's in normal rhythm and who's not. Of course, there'll be no name identifier. Because we think, I think a really good institution tracks their results. You know, a really good institution tracks their results. They know what they're doing. Okay? So we're going to stop. Our next support group will be 2 months from now, and Dr. Zhao,
I might be having a blip.
We'll be
Well,
back.
We'll be talking.
what's he going to talk on?
He is going to talk about closure devices.
Oh, the Watchman?
He said a variety.
A variety of hodgepodge.
I guess the pros and the cons.
How many have actually visited our website and looked at some of the archived stuff? Is it difficult to get to? And okay, folks, thanks for coming. We can take some individual questions for a few minutes.
The website?